shirt. This is very
Boker Tov, everybody. Shalom to everybody here at Kol Shalom. Shalom to everybody on Zoom. We're very happy to be here for our second Tikkun Talks of this calendar year. And I am very happy to introduce Barry Greene, my friend. Barry Greene's been an active Kol Shalom member for almost 20 years. He helps out a lot. He chants Torah, he chants Megillah. And last year he made his debut in our Purim spiel with his adorable granddaughter. Probably being a grandparent, I'm gonna guess, is probably up there in his favorite things. Yeah, favorite roles that he plays in life. So in addition to being the co-founder and chief medical officer of a surgical robotic startup, his day job is as a bariatric surgeon. And since he counsels patients daily in their weight loss struggles and has studied extensively on the physiology of weight loss, we invited him to give his Tikkun Talk today on the principles of weight loss. We're honored and fortunate to have Barry speak with us today, sharing his expertise and wisdom. Thank you so much, Barry.
Thank you, Sally. It was very kind. So let's have a little discussion about the physiology of weight loss. I know that the talk was entitled Psychology in the slides, in the announcement. I actually wrote up that I was going to talk about the physiology, and I'm not really good at checking my emails, so when it came by to approve it, it was just approved as psychology. But obesity is a disease of the brain. The regulation of weight, hunger, feeling, the way we burn calories is really hormonally mediated. So with that in mind, I always do disclosures in every talk. I have obviously no financial disclosures other than I am a bariatric surgeon, and I'm not going to talk about bariatric surgery except as it implies what medicine has learned about weight loss over the last 20 years. And very importantly, these are opinions. What I'm going to tell you today, I'll show you some studies, and those are still not proven. A lot of medicine is not really proven. And you can see, I'll show you some studies back to even 1999 about these hormones that cause people to be overweight and help people to lose weight. But remember, these are opinions, and they are they're brought on or they're developed by my experience. So in medical school, I had no training in nutrition and very little training in psychology. I should actually say no training in psychology. And in the year 2000, I started doing bariatric surgery because patients asked me to. And so I started taking courses. Since then, I've counseled face-to-face over 10,000 patients on losing weight. So I do have a significant experience listening to people who are struggling with their weight and helping them, and then seeing over time what really works for patients. And I want to recognize also that there are many people in the synagogue and in this room who know a lot more about psychology than I do, and the psychology of weight loss. So in bariatric surgery, we refer all of our patients out for psychologic evaluation and counseling. And many of those patients undergo significant counseling to help them with their feelings of the way they look at themselves, the way they feel during the day, how they use cognitive behavioral therapy to help them with situations so that they can lose weight, and even use hypnotherapy very effectively. And those are all areas that I have no experience to go into. So I'm going to work more today on the physiology. The objectives, I hope to help you understand how hard it really is for people to lose weight and why. It's because of the hormones that are involved in it. Evolution has gone from humans living in the savannah 100,000 years ago as hunter-gatherers, and if they didn't feel hungry and chase down an animal or dig for roots and tubers, they would starve to death. So we have an evolutionary advantage to have hunger and to protect the weight we have. So these hormones cause humans, when given adequate calories, to gain weight. So 2/3 of humans are destined to be overweight if we give them enough food. So I'm going to finish by talking about the strategies to be successful, and those are truly my opinions, and I'll give you the punchline right now. Try something. If it works, stick with it. If it doesn't work or stops working, try something new. And there is nothing that I have seen in these 23 years of doing weight loss counseling that works as well as journaling. So we'll talk about that, and I'll show you some data on it. Recently, there was an article in the Washington Post that was very upsetting to me because this person wrote about calories in and calories out, and that's exactly what doctors have told patients for decades, that if you just eat less, or if you just exercise more, and there's no difference, a balanced diet is no different than any of the diets that have been proven to be better. And so I think that it's just too simplified and misleading and unhelpful. Let's talk about the scope of the problem. Across the world, the Global Nutrition Report showed that there are 2 billion adults that are overweight. I mean, that's like 1/3 of the world. And you think about all the people who don't have enough food, or in countries where there is just, there is starvation. But in all of the places where there are adequate nutrition, 1/3 of the world is obese. Children, 41 million children are overweight. And from the United States data to 2017, 2018, the National Health Nutrition Examination, you can look this up on NIH.gov, or you can just search it on Google, but 1 in 3 adults are overweight, 42% have obesity. Yeah, sure.
What is it, the BMI number, like 25 or 26?
I'll give you that to the next slide. Yeah, the BMI is really the best way to define obesity, because it's easy to use. So in children, 2 out of 19, 16% are overweight, significant 20% have obesity, and unfortunately 6% of children have severe obesity. And the trends are even worse. You can look at this from 1966. What happened in 1974 to show that great increase? Well, what happened in 74 was there was a company called Archer Daniels Midland who figured out how to take corn and turn it into high fructose corn syrup. And that has been increasing in utilization throughout the world. And there's another concept called epigenetics, where we can change the genetic makeup, the expression of genes in a population by giving them this high fructose corn syrup. So not enough data to stop a great international conglomerate from doing this, but it's enough for us all to say that if we want to eliminate one thing in our diet, it's high fructose corn syrup. And certainly for a prepubertal child, high fructose corn syrup should not be part of their diet at all. Now on to the BMI, great question. So the body mass index is a number that corrects the weight for the height. The calculation is kilograms divided by meter squared, but you can just look it up on the internet or look at a chart like this. So like a 4'11" person who weighs 176 pounds has a BMI of 36. And a 5'9" person that weighs 243 is a BMI of 36. So it allows us to talk all the way through about a relative number that helps us understand the prediction for disease and death later in life. It's not perfect. There are many people who have very low BMIs that don't have the prediction for disease, very, very healthy people. There are people who have done a lot of weightlifting where the BMI might not predict their level of fat, but across all populations, the BMI is very predictive of developing disease like diabetes and hypertension. Now,
what's the yellow? Sorry.
the yellow is considered, so these are 1953 statistics, and in 1953 they felt like though the yellow was overweight, the green is considered normal weight. So a BMI of 20, under 30 and higher than 25 is considered by the statistics as being normal. However, what we've understood over the decades since is that body mass index is really related to a normal body mass index or an ideal body mass index is related to genetic origin. So for instance, Caucasians of European origin, the ideal body weight is 22.5 to 27. So if you look at the Asian population, the ideal body weight is 20 to 24. And the implication is that as you rise above that BMI, the chance of having disease and death goes up. And if you go below that BMI, the chance of having death also goes up. Now, there's confounding variables in every study, and you might say, well, I know plenty of people that have BMIs of 20 and they're very healthy, but the chance of dying does go up because there's less of a reserve. So someone gets into a car accident or has a trauma, heart attack, or a stroke, their chance of dying is greater at a BMI less than 22.5. And then you might have read about the protective effect of being slightly overweight, and that's related to the same concept. So patients with Europeans of Caucasian origin, Caucasians of European origin that have a BMI from 25 to 27 are protected if they have trauma, stroke, or heart attack because they can withstand the lack of nutrition for a little longer. So it's a much more complex issue, but I think that for most people, understanding that these basic groups helps a lot. So what are the consequences of obesity? Well, it affects everything from migraine, pseudotumor cerebri, which is high elevated pressure in the intracranial space, high cholesterol, fatty liver, metabolic syndrome, which is a syndrome that combines central obesity with high blood pressure, diabetes, hypertension, and sleep apnea, and polycystic ovaries, venous stasis, depression. There's an entire myriad of diseases that come from obesity. So the benefits of 25% weight loss, which is what we would see in bariatric surgery, are tremendous. 57% migraine resolution, dyslipidemia, 63% resolution, obstructive sleep apnea, almost a 90% resolution. Interestingly, diabetes is 83% resolved over all comers with bariatric surgery. Now, there's been plenty of studies that also look at the benefit of modest weight loss. So if someone was to lose just 10% of their body weight, so a 200-pound person loses 20%, they show marked improvement in blood pressure, cholesterol, and blood sugar. This is a great slide. It comes from molecular metabolism this year. Beautiful article showing the benefits of weight loss and comparing all the different ways that people try. So if you look at this, you look here, standard behavioral treatment loses. And so the way we talk about weight loss and its effects across all studies is to look at the percentage of the starting weight loss. So someone who's 200 pounds loses 20 pounds, it's a 10% weight loss. And that allows us to equalize all the data across different studies, say, what is a good weight loss in percentage of body weight? So in multiple standard behavioral treatment studies, the weight loss is less than 5%. Pharmacotherapy, such as phentermine not the GLP-1 analogs, but the topiramate, the combination drugs, those have about a 8 or 9% weight loss. The meal replacement therapy and behavioral modification, if you're able to afford that, has been given about a 12 to 13% weight loss. And combination GLP-1 drugs is really getting into 15 to 18% weight loss, which is really probably the best thing that we have now. The problem with all these is that they've not been studied for a long time. Oops, sorry. There's been a couple of trials, the Swedish obesity subjects trial, that looked at 12-year data on bariatric surgery. So we know a comparator for the longevity of weight loss. And pretty much everyone who loses weight is going to have an adjustment of their body composition to protect that weight. And it's almost universal that everyone on any weight loss program is going to regain some of the weight that they lost. So we don't consider that as, well, the person's not trying, it's just they're trying, but naturally occurring hormonal changes, which we call upregulation and downregulation, will result in people regaining weight. Ozempic, those are called the GLP-1 analogs. So we'll talk about those later. Those are all this area in the purple. GLP-1 analogs are all there. They've been used for weight loss for not that many years. So they first came out in 2010, but weren't used for weight loss till maybe 15 or 18 experimentally. So I'll show you some of the experiments on that as well. This is my favorite trial to look at. It represents over $200 million of our taxpayer money. It's a study that was supposed to go for 12 years, and they randomized. So randomized controlled trials give us the best information. They randomized 5,000 patients to either in a high level of intervention or just normal intervention. And I'll show you in the next slide exactly what those are. And in the group of intensive therapy, intensive lifestyle intervention, the average weight loss at 1 year was 8.6%, which we would consider to be excellent. But when they followed them out to 8 years, it went down to 4.7%. And the standard went from 0.6% to 2.1%. It was very interesting that when the study's primary outcome was to see if intensive lifestyle intervention could result in cardiovascular improvement, decreasing cardiovascular morbidity. And they had to stop the study at 8 years because there was no difference. They called it a finding of futility. This is a little, I kind of tried to highlight it, but this is taken right from the study. Comprehensive lifestyle intervention was intensive for 3 weeks. They met individuals months 7 to 12 monthly. They gave them meal replacements at no charge, monthly group meetings every year for years 2 to 8. So it was about as good as a doctor could do or a nutritionist in a regimented diet program. And they compared that to the standard, which was that they were just going to have, come into the office every 3 months and talk about weight loss with your doctor. So those are the two arms of the trial. It included registered dietitians, psychologists, exercise specialists, cognitive behavioral therapy. So it really, I love this trial when it got started, and I followed, there's over 300 articles written about these patients, and you can read them online, they're all free. And it really showed us how people struggle to lose weight. No matter how hard they're trying, they struggle to lose weight. And this pyramid of what we're going to try is behavior, medical factors. Why isn't it working? Is it because of someone's gut absorbs more calories, or the bacteria in their gut processes calories? Is it environmental? And the studies really show 70% of what is our weight and our response to dieting is really genetic. So it's really the biology of fat that's really making it very hard. Of course, everyone knows fat stores calories, but it's the communication between the brain and hormones that changes the way we burn calories and how we are able to lose weight, and our body protecting us. So let's talk about hormones. I'm going to minimize this so I can see all the slides. Here we go. So a hormone is a chemical made in one part of the body that affects a cell elsewhere. So you know of all the different kinds of hormones: growth hormone, the sex hormones, estrogen and testosterone. But some of these hormones, like the steroid hormones on the left you see here, they actually go into the cell and they react with proteins in the cell to change the movement of those proteins and turn them to and make them turn signals on so that your body produces things. Other hormones come to the outside of a cell and they bind to a receptor. So the hormonal effect is, as you could imagine, based upon the production of the hormone, the degradation of the hormone, and the receptor that it's binding to. So another concept in cell biology is the idea of upregulation and downregulation. Upregulation occurs when there's a factor that causes the body to need an enzyme or a receptor. So the enzyme might be there because there's excessive hormone and the enzyme is breaking down the hormone. So it results in lower effect because that enzyme is breaking that hormone down faster. Or you might have cells making more of that hormone based upon another hormone. So the reactions are very complex. But what we can remember is that if someone goes on a starvation diet for any reason, they will downregulate the enzymes in their intestines to break down foods. So if one goes on intermittent fasting or a low carb diet, and then you try and eat carbs, your body will feel queasy because you don't have the enzymes to break down those carbs. So one of the benefits of dieting is that you improve your ability to regulate your weight. Fighting that is this hormone leptin. So we'll get into the leptin. It's also a great scientific experiment that occurred in a minute. But I want you to focus on here on the right side that hormones occur that, like epinephrine is a hormone. That's the hormone for fighting and fleeing. So these are things that we really understand very well, and they're throughout our body, and they really are responsible for our cravings and our desires to eat. So this is how complex the hormonal milieu can be, and you'll see there's in the brain here depicted by the blue, we have these pathways. The most well-studied pathway is the MC4R, which is has a gene expression. So there's hundreds of genes that have been identified that are responsible for our weight. And while this is very complex, this is more of easier to understand. The stomach makes a hormone called ghrelin. Ghrelin goes to the brain and enhances our hunger. Ghrelin is made by the stomach in response to a mixture of carbohydrate and fat. And we all know this because we serve appetizers. What's the best appetizer? A Ritz cracker and a little bit of cream cheese. It causes hunger in everyone about 15 minutes afterwards because it stimulates ghrelin. So if you respond to that, you think, well, I'm gonna have, if I'm hungry and I come home from work, I'm gonna have a vegetable, like a carrot or some celery, and avoid the acetylated, they're called acetylated fats, that will enhance our hunger. And the Greeks knew that because they served carbohydrate and fat prior to meals to enhance their hunger. The next hormone I want to talk about is leptin. Leptin is made by the fat cells, and leptin, as it's produced, it actually decreases hunger. So a leptin deficiency results in insatiable hunger. We all know about insulin. Insulin is made by the pancreas. It goes throughout the body to help us utilize our blood sugar. This newer one here called GLP-1 is made by the intestines, and it has multiple functions, including decreasing the speed of the transit of our food, which kind of makes us feel full. It goes to the brain and it enhances the sense of satiety and lets us feel full longer. So the rest of them are not as relevant now, but I want you to understand that obesity is a spectrum disease. It's not the same in every person, so we all have different physiology that results in our ability to manage our calories differently. So this is really the landmark article. New England Journal, 1999, a brilliant physician, researcher, Dr. Sadaf Farooqi and her team in Cambridge found a cohort, a family that had, everyone in the family had childhood obesity. And they studied the genes back in 1999 and identified that what was missing was this MC4R gene and resulted in no leptin. And these children all had morbid obesity. This child is 6 years old. So what she did was she synthesized leptin, gave it to the kids in the family, and they became normal. So this really helped us to understand it was leptin going to a leptin receptor that in the brain that decreased the desire to eat. Isn't that fascinating? That really is someone who's brilliant in understanding the physiology of what's going on here and saying it's not the person's fault that they're eating like they are. It's the cravings that come from these hormones. Now, the new one on the block is GLP-1. GLP-1 was identified because of bariatric surgery. When I do a gastric bypass, it almost shuts down by 90% it increases by 90% the GLP-1 when a person eats. And because of that, they were able to identify GLP-1 elevations as a gut hormone that could be used to decrease hunger. Before they figured that out, they also noticed that GLP-1 fed back and increased insulin production by the pancreas. And in fact, 6% of patients that have bariatric surgery, have a gastric bypass, have excessive GLP-1 so that they cannot tolerate any carbohydrate intake at all. Otherwise, they'll have excessive secretion of insulin and their blood sugars will plummet. They have what's called reactive hypoglycemia. They eat sugar, and instead of their blood sugar going up, it goes down. So GLP-1 was first identified because of its effect on insulin control, And later, it was identified that it would delay gastric emptying and reduce appetite. And so now there's an entire list, which I've included there on the left side. Wegovy is a drug that was studied for weight loss. Ozempic is the exact same drug, which was marketed for diabetes. Just last week, there was a drug approved by the FDA called Mounjaro, which is another one of these GLP-1 analogs that will be a pill. And there's a Rybelsus, which has been a pill, but that's not been approved for weight loss yet. So very interestingly, again, I love to look at these studies. This was a study that came out in April of 21. It compared use of Wegovy to another drug, but most importantly to placebo. And it showed that there was in 803 patients randomized and then crossed over, almost a 15% weight loss. A bariatric surgery results in an average of 25% weight loss. 15% is well above what we need in order to show a marked improvement in diabetes and dyslipidemias. So it's my hope that the government will jump on this and realize that they can affect childhood obesity and the progression to adult obesity by providing GLP-1 analogs to kids. And now that we have 2 GLP-1 analogs that are available in pill form, it may be better tolerated. The downside is that over 80% of patients that we prescribe this drug to have nausea. So you have to ask yourself, is this something that is good for society to walk around nauseated? But most people get used to it after a while. It definitely decreases hunger. You can decrease the dose. You don't have to go to the highest dose. And when people are plateaued, about 40% of patients describe daily bouts of nausea. So it's definitely a compromise, but on the benefit, it results in a marked improvement in diabetes and in weight. Again, I want to really stress that treatments have a variable response based upon the patient's physiology. And of course, this is just a standard bell-shaped curve I stuck on the slide. And it's just there to help us understand that both the response amongst patients and the response amongst individuals changes over lifetime. So our hormones change, not just the sex hormones, but the intestinal hormones also change from puberty, from pregnancy, menopause, and daily with stress. So some people might have greater hunger with stress, and others might have a higher metabolism with stress. So it's very difficult for us as physicians to be able to prescribe these medications without having close interactions with patients. And that's why I say if something works, stick with it. If it doesn't, keep trying. So my recommendations, I believe that accountability and evaluation of progress is the single most effective tool that I've uncovered in patients to lose weight. I also like elimination of specific foods, and I like to try and alter physiology through downregulation and hunger by meal planning. But if we look at, here's a study of self-monitoring and weight loss, a systemic review, there was a lot of evidence for consistent and significant positive relationships between self-monitoring diet, physical activity, or weight and successful outcomes. So I've seen this over and over again. If I can get someone to journal just for 2 weeks, then they'll be able to take themselves through work, through a weekend, a different situation at work, I ask them to journal their exercise and all the foods and drink that they take. And by doing that, most people know what to do before they even come and see me. And it really helps to try and understand, and then they can work with the nutritionist, or the psychologist, or me, or the nurse practitioner, and really begin to understand strategies, because it's often a different food that's creeping into someone's life, or it might be a liquid. So diet theory is really, there have been hundreds of diets, and I tried to kind of summarize the different kinds of diets here. Portion control is a standard therapy, diet therapy, that's been taught to nutritionists for decades. And when I started in weight loss surgery, it was what all the nutritionists were teaching. And we were using a low carb model. Weight Watchers for many years used a point system to try and help people with just a balanced diet, with the old pyramid of the majority is carbs, less fats, and lower proteins at the top. But in most studies, that has the least benefit of all. And then there's the Ornish diet, a low-fat diet. The Ornish diet is the most unpalatable diet because fat is what makes food taste good. But it works really well. And if one can get their percent of fat down lower than 5%, they can actually reverse the atherosclerosis in the heart. So that's pretty amazing for someone who's got severe atherosclerosis and doesn't want to have a cardiac bypass, but it's not a commonly used. Intermittent fasting, instead of controlling the food that you eat, it controls when you eat the food. And the thought behind intermittent fasting is that, again, you can down-regulate the enzymes in your intestine by going through a long period of starvation. So when we go to bed at night, every human changes the hormones. When we eat our meal, we deposit the fat and carbohydrate into the liver. It's the largest organ of our body. And overnight, we utilize all that rapidly available carbohydrate called glycogen. And when we're done with the glycogen, our kidneys or our adrenal glands start to make epinephrine. And the epinephrine causes the liver to begin to turn some fat into a form of carbohydrate called ketones. And that's why everyone wakes up in the morning and they're not hungry, because we have this condition called ketosis, where our body's producing these ketones, and ketones actually decrease hunger. So that's the reason that this intermittent fasting works for some people who can tolerate waking up in the morning and not eating until the afternoon, and then eating one big meal and then going back to bed again. So I don't like it as a way to start dieting, because most people struggle with it. But there's a few people who tolerate it, so I think it's okay for them. The majority of successful diets are low carbohydrate diet. There's the Mediterranean diet, which is good quality fats and grains and works really well. Atkins, ketogenic fat burners are all very low carb diets, and they have problems with fat consumption because they're unhealthy, depending on if you read the books and you follow what those diets say. They're unhealthy because they don't regulate fats. They say, well, bacon is better and cream cheese is okay, because they're trying to use fats to diminish hunger. It is effective, and people have lost a lot of weight on these diets. However, the high fat content isn't healthy long term. The paleo diet is a similar diet using high fat foods, but no processed foods. So there is some some people who like that diet, and I think it does have a little bit more benefit if you do a paleo diet and you cut out the red meats. It's probably acceptable if you look at the overall diet plan. I think the South Beach is the best diet out there. When my patients are at steady state and they're leveled off and happy, it's a very healthy carb diet, healthy fat diet. A cardiologist wrote the book on it and designed the diet, and I think it's a really good diet to live long term. So now, to understand the diets, if we think of a 2,000 calorie diet, every food breaks down into either proteins, fats, or carbohydrates. So you can look at them like, fish and shellfish. They're mostly protein, but also have some fat in them, depending on the fish. Like salmon is almost 50% fat, but it's a good quality fat. Olive oil is pure oil. It's a pure fat, but it's a good quality fat. Cheese is half fat and half protein. Eggs also the same, half fat, half protein. Tofu, half protein and half carbohydrate. Also good quality protein. Chicken, if you take off the skin, excellent quality protein. And I recommend people avoid red meat no more than 2 or 3 times, because there's a lot of data to show that consumption of red meat is associated with increasing cancer. 2 to 3 times a week. That's what's recommended by the NIH now, is that you should avoid going more than 2 to 3 times a week because of the association of cancer. But if you look at the bottom of the screen, the calories from protein are 4 calories per gram, and carbohydrates are 4 calories per gram. If you say, I'm going to eat a moderate protein diet, 1 gram per kilo, so it's 60 or 70 kilograms of protein, you've got about 240, 280 calories in your diet. And if you have a moderate fat diet, moderate fat is like 30 to 70 grams of fat a day, you're looking at about 540 calories, which means that really the only place to cut out calories in a diet is carbohydrates. So that's why I say the only diet that really works is a carbohydrate diet. If you go to a really low fat diet, it's not really palatable. And there is no such thing as a low protein diet. There's not many calories in the proteins we eat. So it comes down to eliminating carbs. So how do you eliminate carbs? You could do portion control. And again, my wife is, she has a degree in nutrition in addition to being a rheumatologist before she went to medical school. And she believes that portion control is the answer. In my experience, portion control just doesn't work for people. But abstinence works much better. If you say, I am absolutely never going to eat a potato again, it's a lot easier than saying, I'm gonna eat a little bit of potatoes. So I find that's the strategy that I use the most. I tell my patients, look, eliminate pasta. Pasta is really not that bad for you, but eliminate rice and potatoes first. Eliminate all calorie liquids. And if you can do that, you will crowd out. You'll make it harder for you to get that amount of calories and carbohydrates, because what's left? Vegetables. So you have 2 portions. You make broccoli and cauliflower, or you make beans and asparagus, and you throw in some legumes. Legumes are good. They're 50% carb and 50% protein. And that's where the journaling comes in. Once you journal, you can understand what is in your diet, and it makes life a lot easier to utilize these strategies and lose weight. All right, my final recommendations: eliminate caloric liquids, eliminate high fructose corn syrup. Don't ever serve potato chips. There's no reason to serve potato chips. I want to ask the rabbi, there's no reason. It's almost like disrespect for humans to serve potato chips. When you go out to a restaurant, or someplace, they're just serving it to you because they're cheap and people like them. So if you just eliminate them, they shouldn't be served to kids at all. And definitely to kids, don't serve high fructose corn syrup. And we say anything that comes in a bag, a crackly, crunchy bag, don't bring home. It shouldn't exist in your house. Let them do it in college if they want. So down regulation, periods of low carb existence. Even if you can do a month at a very low carb diet, like 800, 900 calories, you will down regulate the enzymes that allow you to eat carbs and digest them, and you'll feel full faster over time. And the longer you can maintain that low carb existence, the happier you'll be. Avoid hunger by meal planning. So plan good choices in your pantry, at work, during travel, so that you don't get really hungry. I think when people get hungry, they make poor food choices. At home, healthy snacks, vegetables available in the refrigerator. Slow down, put your fork down between bites. Put it on the plate. Drink a lot of water with your meals. Purchase slightly smaller plates. It sounds silly. Here we get to my two silliest recommendations. Instead of having a 12-inch plate or an 11-inch plate, get a 9-inch plate, and you'll fill it up with less. There's a lot of studies that show that people who live with smaller plates eat less food. I'm not sure it's really scientific, but I think it works for a lot of people. And then when you serve your dinner, an easy way to decrease the chance of you just picking at food is by putting the extra food on the counter away from the plate that you're eating on, so that you have to get up and get the second portion. It's not going to stop you, but it'll slow you down. Those are silly things. All right. In summary, losing weight, controlling weight is hard. I think the hormones, it's really not a person's fault of their weight. We really can't say that a person who's thin is thin because they've got better self-control than someone who's heavy or morbidly obese, because it really is the genetics behind it. Obesity is a disease. It's a problem with physiology behind it. It's not a choice. And I think that's the biggest thing. People talk about food shaming. I think the answer is not shaming people because of their weight. Evolution has really programmed us to have this kind of metabolism, cravings, and hunger. And if it works, stick with your diet. If it doesn't work, stop, try something else. We do that in our office. In fact, when I prescribe diet medications, if someone has not achieved 5% of weight loss in 12 weeks, I don't re-prescribe it, because it's just not worth the risk isn't worth the benefit. And then there's nothing more effective than journaling. Thank you. Thank you for your attention. Any questions? Yes. Please.
Well, the other question is, you could speak about your recommendation to lower high-calorie fluid intake. Could you speak about replacing high-calorie liquid with diet soda, say, versus just like water?
That's a really great question. And I didn't get on to the physiology of sugar alcohols. So diet sodas, diet drinks, even almost every one of the protein shakes on the market have these variations of sugar that are poorly metabolized by humans but are sweet. Some people, they have been giving a problem with physiology, so I try and tell the patients not to take them. But they're really hard to avoid. And for someone so again, we have to take the recommendations that I've been giving for people who are trying to lose 10% or more of their weight. For people who are either exercising a lot or are thin naturally, then potatoes are great, and calorie liquids are fine. It's really just for people who are trying to lose weight. So I try and say that even natural juices for someone trying to lose weight are not really good. Yes, Alan.
Speaking about on the individual level, but as a society of 350 million people, it seems to me that it's clear that obesity is correlated with poverty and inequality. And being obese is now a marker of poverty, whereas being fit is a marker of affluence and education. So it seems to me that although your interventions might work in individual cases, they're not going to solve our problem as a nation, as a society, and the only way to do that is through political interventions to raise people out of poverty and to flatten the inequality in the country.
I agree, thank you. And the other thing is that we as a society are too influenced by corporate America. Just recently, they put Lunchables on school lunches, which is ridiculous. They should be teaching people how to eat for school lunches in addition to serving them. Fast food chains, it gets back to frying potatoes results in a pheromone, a hormone or a chemical in the air that induces hunger. So we should, as a society, we should spurn all French fries. Fried foods are, McDonald's figured it out in the 50s that they could make, for some reason, if you fry potatoes, people are hungry. And fast foods are not healthy. So you're right, until we're able to get greater equity in our society and our healthcare, obesity is going to be a problem. Yes, sure. Well, that's a very good observation. I think that we perceive a person who is 150 or 200 pounds overweight that loses 100 pounds and regains 30 as a failure. But they're still 70 pounds down from where they started, or 15%, 18, 23% in the example that you mentioned, he's not back at his starting weight. So it's not a failure, it just is a misperception of what we're seeing and thinking, oh, that surgery should be perfect. It's sort of a prejudice that we have in society against obese patients, against obese people. And that prejudice allows us to say, well, they should be perfect. That surgery should be perfect. But if someone has cancer and they get a recurrence to their cancer, we don't ever say, look, it's that person. Or they need a heart, they need a heart valve, a heart stent for atherosclerosis, and they need another stent, then it's the failure of the person. We say it's a progression of disease. Obesity is a disease. Yes, please, David.
Well, let me follow up on that one. Because you said, like, if somebody's missing leptin, then they're very hungry to get obese. So there's two questions to this. One is, so where do you go to find out of all those hormones you can test? Am I lacking in one or need one or something like that, which would help? So is there a place to get this sort of test? Because my cousin also had bariatric surgery, lost a lot of weight, and because that may be like if I take Ozempic, which I do, then is there something else going on that keeps the weight up that I don't know about?
So we can't test yet about which medication or what gene is missing. I'm sure it can be done, but we don't do that routinely. Right. And the same is going to happen with Ozempic. People are going to lose a lot of weight and then they're going to regain some of it. because the same is true for blood pressure medicine and every other medicine that we do. The disease progresses as we get older, and we think that in obesity, we think it's the person's fault, but in all the other diseases, we think it's the disease. Yeah, Bill?
So, in your own practice now, how has the GLP-1s affected what you do with patients? When you start the diet, and before you get to a gastric bypass, you put patients on medicines like GLP-1, and when they fail that or are not happy with the outcome, then you go to surgery. Common. There's more than one kind of bariatric surgery, right? The most common one, if I'm not mistaken, is the gastric sleeve these days. Right?
Yeah.
You quoted 25% weight loss. My impression or my recollection is that's for the gastric bypass, the most severe one.
Yeah.
Is that a number you would quote for gastric sleeve too, the most common?
Yeah, no, I quote 22% with sleeve, which is, I'm still happy with. Yeah, and so when our algorithm, when people come to our office, is to talk to them about diet and exercise, and if they either can get a one of these GLP-1 analogs because they're diabetic, then we put them on that, and we follow them along for 3 to 6 months. If they're losing weight, we'll continue it. It's uncommon, it does happen, a couple of patients a year, that people lose so much weight that they don't want to have surgery anymore. But it does happen. And we encourage patients to do that. Most commonly, people use, oh, you have a question? Okay, we'll get it from the chat then. So most commonly, people utilize the GLP-1 analogs and other medications to lose weight in preparation for bariatric surgery, because as you can imagine, it's much less risky the lower a person's weight is. So if someone's got a BMI of 60 or 70, it's a higher risk for obesity than if their BMI is 35. So if I could bring it down, it just helps everybody. Did I get all your questions?
So you do start them on GLP-1.
Yeah.
Most of them want surgery.
Yeah. Most people do. Yeah, they're just using the GLP-1 to prepare them. Well, or it does help them. So let's say, honestly, if someone weighs 350 pounds and I can get them down to 300 pounds before surgery, that's much safer. Safer for, it's easier, it's safer, less work on my arms, trying to move around. So it's all good. How do I get the question on the chat? Uh-oh, can you come up and help me? Where do I see it? Under more. It's under more. There you go. Thank you. Okay. Are nuts a healthy snack? Absolutely, as long as you don't eat too many of them. Nuts are 50% fat and 50% protein, but there's a lot of fat. It's good fat, but I have had patients who've lost weight and then they regain weight a little bit. And when we look at their journal, we see that it's because instead of eating 15 almonds, they're eating this many almonds. We tell them, you can have almonds. It's definitely a good snack. But, again, that's where portion control comes in. Yes, please.
Two questions if you have time. First, going back to the where you provided chart with BMI, most members of the congregation were both up 13 and 80%. So just like average the two respect overweight or like how do we
That's a really great question, and I should delve into that deeper. So what happened was we had these BMI criteria, and the BMI criteria said that someone could have weight loss surgery at a BMI of 35. And so we started following patients along for diseases. And great health system called the Indian Health Service in Asia did a longitudinal study, and they showed that people from Southeast Asia had higher incidence of diabetes and sleep apnea at BMIs of 27.5. And so they were seeing the same increase in diseases that we were seeing. And it's only been over the last 10 years, maybe not even 10 years, that we as a society of physicians have decided that we're going to understand the populations that we're studying. I just went to a meeting with the American Association of Gynecologic Laparoscopists, and they had an entire session to try and understand that all of the data on obstetrics and gynecology is all on white American women. And so they made a conscious effort that they will now require all papers for publication from here on must have a representative population from society, diversity, equity, and inclusion. So yeah, I would say, again, using population statistics for an individual person is hard, but depending, so for you personally, I would say, you're not, yeah, I wouldn't worry too much at your weight.
My second question, if you have time, I know your talk was not specific about psychology, but I do want to ask a question about psychology. Kind of this spice maybe. So this year I started intermittent fasting, not necessarily because I wanted to lose weight, but inflation is high, I didn't want to buy groceries, also I don't like cooking. So I just kind of did just by default. I noticed over the summer that when I wasn't eating in the mornings, like my anxiety, and I did not eat something. So this kind of goes back to when we talk about hormones, but it's, I guess from my personal experience, it seems that when you do kind of fasting diets or a different diet, like there can be some anxiety and some kind of like mental, emotional frustration involved. So how would you tell patients who are like, I just have to eat the three things done?
So yeah, that is really, I think that's the greatest summary question I could ever get. It is to say that the response to fasting in some people is an outpouring of epinephrine, which causes anxiety and increases their metabolism, but the anxiety is a problem. So for those patients, I recommend, and it's not a small amount of patients that cannot tolerate fasting. That's why I said I don't really like it. I have a lot of problems with patients having intermittent fasting. And I tell them, have a protein shake available to you, because then if you take a carbohydrate, it should be a complex carbohydrate, but don't take a simple carbohydrate, because that will raise your blood sugar, increase insulin, which will then cause more hunger. But if you treat that with, with a protein, or some nuts, some berries are good because they have a very low glycemic index, especially blueberries, strawberries, and other proteins like a hard-boiled egg, some things that are easy, a piece of string cheese. Those can all fit into that space to decrease the ketosis and help you feel less anxiety for it. And that it is a problem that we see. Back to the chat. Okay, I'm supposed to repeat the questions. Thank you. I'm so sorry. Has recent research into gut microbiome shown any promise for weight loss? Yes. So the gut microbiome is the bacteria that get through the stomach. Typically, the stomach has a lot of acid in it, and it kills bacteria. So the intestines below the stomach are mostly, the small bowel up to the colon, the small bowel is mostly sterile. In some people that have lower acid levels or taking these things called proton pump inhibitors, antacids, or have bariatric surgery, the flora, the bacteria in the mouth, get into the small bowel, and they change the way we metabolize food. They also markedly increase GLP-1, because food in the small intestine causes an elevation in GLP-1. And so they get a natural hormone that decreases their hunger, slows down their intestinal tract, and allows for weight loss. And that's probably the greatest way that bariatric surgery works. But I don't know of any gut microbiome medications or ways that we're going to use gut microbiome in non-surgery. There's experimentation going on with surgery to go down endoscopically and take a plastic sleeve and put it inside the small bowel so that food is shuttled out of the stomach, but it hasn't gotten it past the FDA yet. It's been a lot of trials. There's other trials where you can go down and hook the intestines up with a magnet. So there's a lot of research going on, but nothing yet. And David, thank you for your comment. The question that I answered before was about intermittent fasting and how it affects hormones. Thank you all for your time and your attention. It was a lot of pleasure, a lot of fun. Thank you.